Waiting just a moment to make sure the last people get signed in and checked in. And as with regards to the PDF file for the notes, I'll be putting that up on my webpage as soon as the presentation is over. Right now, obviously, the notes are going to be in front of us. So I'll get those up just immediately after the presentation. And I see that you're on, Joseph. And we've got a couple of phone participants. For the phone participants, I'm sorry I don't have the PDF notes up just yet, but I'll get those on shortly after the presentation. And we'll be recording today's presentation, so you can just also, I'll put the recorded version of today's webpage up on my internet site so that you can review this as you desire. So anyway, let's just get started. This is part 3 of building a comprehensive nutritional practice. And today is really a continuation of part 2. Part 2 was the beginnings of the symptom survey and working on the upper digestive tract. So today we're going to be working on the lower digestive tract. So for those of you that are sort of new to the building a comprehensive nutritional practice series, the first two classes are on my webpage. So if you go to www.parkcountychiropractic, and under the practitioners tab, there's a little teleconference access, and if you click on that, you'll be brought to a login screen where you can put your username as EAT and your password as healthy, making sure to remember to capitalize the first letter of those two words. That'll get you onto the web page, and when you're on the web page, it's going to look like this once you've logged in, and you will see, for instance, part 2, session 2 of building a comprehensive nutritional practice here. So that recorded webinar, you just click there and it'll take you to that. And part 1 is down here. You'll also notice several sets of notes from previous Montana nutrition collaboration teleconferences that we've had over the past couple of years. So with that, we'll just kind of move into what we're working on today, which is still group 6 of the symptom survey. This is the digestive component. Even though this is the shortest component of the symptom survey with regards to the amount of questions, it's arguably the most important, which is why we're spending 2 sessions on it, and why we're spending splitting this up into not only just the upper digestive component, but the lower digestive component. So lower digestive, the questions that are more pertinent to the lower digestive function are questions 99, 101, 102, and 104. And from an examination standpoint, with my patients, I'm looking at the large intestine. I'm palpating large intestine. I'm palpating iliotibial bands. We'll go over that later in the presentation. And I add a few other sort of objective exams to make my digestive examination a little bit more thorough than just what's on the nutrition exam. So I want to read a quote from a book that I really recommend and I utilize quite a lot, and it's from a doctor named Alex Vasquez, and I think he puts it pretty eloquently when he says, "Human physiology is complex, and treatment plans must be multifaceted to reflect this complexity. Cells, tissues, and organ systems work in concert, not in isolation, and therefore effective intervention generally requires improvement in numerous organ systems. As the artificial boundaries between organ systems dissolve, a unifying theme emerges, namely that the attainment, preservation, and reestablishment of health must be all-encompassing. Programs and paradigms related to the treatment of disease and the attainment of optimal health must reflect appreciation of the environmental, physical, mental, emotional, nutritional, biochemical, hormonal, immunologic, neurologic, and gastrointestinal components of our existence that coalesce without boundaries to make the human body and our experience of life itself. Thus, new frontiers in healthcare will be reached not solely when new discoveries occur, but also when the integration of these discoveries into a cohesive, multifaceted, unified healthcare model prepares the way for a more accurate understanding and more effective interventions. Healthcare providers of diverse backgrounds can and must work together to offer scientifically based, multifactorial interventions that are adapted to the specific needs of individual patients. So keeping that in mind, this is how I want to approach my patients. This is how I want to work with my patients. And today we want to think about that in context to the lower digestive tract. So the lower digestive tract for today's purposes is going to be everything from basically the pyloric sphincter down. So we're looking at primarily small and large intestine. I may call it the bowel. So the bowel can encompass the small bowel and the large bowel. So what's the role of the lower digestive tract? Well, the lower digestive tract really has a couple of roles, primarily being absorption of nutrients that bring energy and sustenance to the system, body as a whole. Of course, it has a role in the elimination of waste, and its other important role is to provide a protective barrier against things that are potentially harmful or not self or non-self. So if we start, in simplest terms, looking at the gross anatomy of the small intestine, this is a pretty profound thing because what we essentially have is about a 22-foot long tube, the small intestine, and maybe 4 to 6 feet, a large intestine. So let's say 30-foot long tube. It's not terribly large, and if you were to cut it open and lay it out, you wouldn't think it was all that big. But if you consider the circular folds and the villi and the microvilli, and you were to spread that surface area out, the small intestine has a surface area of about 250 square meters, which is about the size of a tennis court. Comparing that to, just your skin, if you were to look at the area of your skin, which is about 2 square meters, you can see that the small intestine is by far our largest interface with our external environment. And that's important because ultimately the job of those enterocytes is to absorb food. And when we look at, this is kind of a slide that shows what the average American is. So if we take into account men and women, the average American is consuming about 2,000 pounds of food per year. So if you're living to 75, you're eating 150,000 pounds of food in your lifetime. That's a lot of interface with our external environment. And if we're doing it correctly, we're breaking that down to the molecular level. And that's elegant and pretty profound when you consider it. So let's kind of review the process here. We're breaking those food particles down, and for instance, we're taking our fat-soluble vitamins through the micelles that hopefully our good gallbladder function has broken down. We'll talk about that next month when we go and deliver gallbladder function. And we're taking that through the enterocyte. So this cell here is an enterocyte. And we're taking it through the cell. We're taking it through this membrane and then through this membrane. And we call this type of absorption transcellular, sometimes called intracellular. So this is what we want to do. We want to take these nutrients through the cell. And in this case, the fat-soluble vitamins packaged up in their little micelles, their little chylomicrons, are going to be skipping the liver, and they're going to go through the portal circulation, which is very important. And we'll talk about that briefly in a moment. And secondarily, we have the water-soluble nutrients, particularly the B vitamins and vitamin C, and those are going to go transcellularly as well, and those are going to be the ones that are dropped into the portal circulation to the liver, whereas the chylomicrons are going to skip that portion of circulation and go right into the thoracic duct for delivery to the more peripheral circulation. And I make a point when I'm talking to my patients about fat and fat-soluble vitamins and their importance to the heart, is that the heart gets pretty much first dib on those guys. So, and the liver doesn't get a chance to process that till the heart has had first dibs. So when people are saying, well, I need to do a low-fat diet for my heart, I remind them that the fat and the fat-soluble nutrients don't go to the liver first; they go to the heart. Who would design a system to give first dibs for something that was bad for it? So remember, fat is good for your heart. Secondarily, the other type of absorption that we can get is through or between the cells at the tight junction. So when we're talking about the situation where we talk about leaky gut is a situation where the tight junctions are failing or not as efficient, and foodstuffs and hopefully not whole proteins, which is what happens in food sensitivities and allergies, sneaks through the system without being appropriately broken down. Very small particles can get through the tight junctions. They're built for very small particles. But if we start letting larger protein molecules through, this is kind of the genesis of leaky gut syndrome and food sensitivities and things of that nature. So, of course, all of this absorption would not mean a whole lot without portal circulation. So portal circulation is all of those nutrients that have just been absorbed from the small and most of the large intestine gets taken through those tributaries to the liver. Of course, the liver is going to be responsible for storing, packaging, and distributing those nutrients for the rest of the body's use. So we cannot have good digestive function without good circulatory function. So remember, we cannot look at these as separate systems. We can think about them that way, but this is an elegant machine and it all works together. So the circulation is obviously very important. And just sort of an aside is this is kind of off topic, but Antranex, which is one of my favorite products, really works on the portal circulation. So you can see on this note that, at the bottom, the total liver blood flow is quite high at about 1 liter per minute and up to 2 liters a minute. That's on average about a fourth of the cardiac output. So there's quite a big change in how much blood flow can go through that hepatic portal vein. And Antranex influences portal circulation. By improving or upregulating portal circulation, we get more liver filtration, and this is one of the ways that we can rid our body of excess histamine. This is one of the reasons why when you look at the Therapeutic Food Manual and other of the old writings of Dr. Lee and others, when they say, give Antranex for a headache, oftentimes headaches are pressure in the venous and arterial system, and we can lower the pressure in the peripheral circulatory system by improving blood flow through the hepatic portal circulation. That's what Antranex does. So I'm off my aside, and we'll get back into the digestive function. So again, we were kind of up at this slide where we're the roles of the lower digestive tract. What we want to talk about now is the protective barrier, or the sort of immune system interface with our outside world. So when I'm talking with patients, I really like using the TSA check station at the airport metaphor, because it stands pretty well to comparing and contrasting. Because ultimately we've got all these potential travelers going through the small intestine, and many of them we want to get on airplanes and get to their terminals, which is going to be the portal circulation in the liver for delivery to the tissues everywhere. However, we have the burden of making sure that we're not interfacing with terrorists, or in our case, our guts case, pathogens or opportunistic or pathogenic bacteria that could cause harm or disease. So really the small intestine, I think of it as, well, as our immune system. This is our biggest interface and our TSA check stations. So a vast amount of our immune system efforts and energies are placed into the small intestine. This is where we're making levels of secretory IgA. So we're making antibodies that are going out and checking all those little particles of 2,000 pounds per year, 5 pounds a day of food, and trying to determine, is this food and therefore absorbable, or is this a non-self entity that could be damaging? And if it is, then it's properly disposed of and escorted out into the toilet. So this next slide is kind of a little bit more of a better cartoon or graphic representation of just how much immune system activity is going on. While we do have obviously all the typical enterocytes, we have quite a vast amount of immune cells, B cells, plasma cells, making secretory IgA, which is giving us the ability to do these very quick spot checks of the things that are going through the intestine. So that these IgA molecules are important because they're doing a lot of the kind of early screening. This is kind of like the first guy at the TSA check station that's kind of shouting to everybody, listen, throw away your water bottles and get your toiletries out, and they have to be in this bag. So these are the first little guys that are kind of making the checks and determining who's good, who's not. In fact, secretory, or in this case, intestinal IgA levels, can be correlated to the overall health of the gut. So later we'll talk briefly about a lab that tests for secretory IgA levels, and that is one of my objective means of determining the health or integrity of that patient's small intestine. Of course, no review of the bowel would be complete without paying some attention to what lives there. And in this case, we have a host of bacteria that lives in our intestinal tract and in our entire digestive tract, for that matter. So they say upwards of 500 different species of microflora and 10 to the 14th power of microorganisms. So that's in the tens of trillions amounts of good, opportunistic, and potentially bad bacteria at any given time. Of course, the majority of those are going to be found down in the distal part of the small intestine, and the vast majority of it's going to be in the colon. And when you look at the sheer numbers, you know, our human body cells are only in the billions, whereas our intestinal microflora is in the trillions. So you can see how profound an impact on our system can be made by having a healthy intestinal microflora. So when I'm working with my patients, what I'm really trying to do is get down to the nitty-gritty of what it is that is going on in their system. So I pay very particular attention to what I'm seeing on any given presentation. I often go well beyond the questions of the symptom survey and get a little bit more deeply into what their poop is like. So if I see questions that are obviously related to digestive function above and beyond that, before I even start my nutritional exam, I'm going to be asking, how often do you poop? Do you have to wipe a lot? Is it a real nuisance? Is it really squishy? I get pretty in depth with that because I think it gives me a better opportunity to understand what may be helping them to improve that. And if I can notate that, then I've got something to look back upon where I can say, oh, Ruth, last month, remember how you were saying your poop was all squishy and now it's not as bad. That's good. I mean, if you're using less toilet paper when you defecate, that tells me we're getting a cleaner, more efficient system and doing the job of digestion more effectively. So one of the things that I found that's kind of missing from that digestive component is a pretty important question, which is constipation. And you'll notice that constipation is in the symptom survey. It just happens to be in the parasympathetic section, which is group 2. So I'm always paying attention to those questions that correlate, even if they're outside of the particular section that I'm scoring. And in this case, we're looking at digestive function, but constipation is obviously a pretty important component of that. So now as I start to look at my patient more objectively, so I've done my subjective, which is symptom survey and history. Now I'm looking at more objective means of determining what's going on, what kind of things are happening. One of the simplest and inexpensive ways to look at how bowels are functioning is the patient's bowel transit time. So this is the time it takes for the food to travel from the mouth to the toilet. And this is obviously affected by the amount of bacteria in their colon, how much fiber they're consuming, and obviously water, because water provides some of the lubricative factor that bulks that fiber up and allows it to move through the tract. So the way that I tend to do it with my patients is I have them eat a beet or two, or I may have them just eat corn and track when they ate that meal, and then determine when it comes out of the toilet. and get a time frame. So if they had supper at 8 o'clock at night, and the next morning they woke up at 7:30 with diarrhea and they see that corn or that red stool, I know that that transit time is very quick or far too fast. That's not nearly enough time for the small intestine to do an effective job of removing all the nutrients that would be necessary to keeping that system viable. Similarly, if it's 2 days later and nothing's shown up, then I know that that transit time is slower, and that's going to be a strong sign of toxicity and obviously problems. So I'd like to see that transit kind of be in that 12 to 14 hour range. And most of all of that should be gone by 36 hours. I don't usually see it that long. Usually if it's going to start at 12, it's going to be done by 20. The other thing you can do is you can use charcoal caps. The concern I have about using red beets is that, well, I know that beets are really good at influencing bowel motility. So I may get an artificially quick reading because the beet is so effective at improving colon function. So when I have a person that has constipation, I typically, one of the first things I'll do is say, particularly when they call me on the phone, I say, just go out and buy some beets and bake them or do whatever it is you want and eat an entire whole beet, and that should get you moving, should get your bowels moving. So that's why charcoal caps can be really good. And that's why whole kernel corn can be good, because I don't think those tend to stimulate bowel function nearly like a red beet will. But if nothing else, the red beet is something to consider. Which leads us to kind of the next idea, which is this whole thing of fiber. And so there's two types of fiber. There's soluble fiber and there's insoluble fiber. So soluble fiber, obviously, like its name suggests, it dissolves in water, and it's found in fruits and legumes. And what it does is it tends to slow transit time, whereas insoluble fiber is not water soluble, particularly found in the skins of vegetables and fruits, and that tends to increase the bulk, and as a result, it tends to reduce the transit time. So if I'm going to work on a patient with constipation, I want to make sure that I'm doing a product that's primarily built around a mix of, or mostly, insoluble fiber. So there's a new product from Standard Process called prebiotic inulin, and prebiotic inulin is a soluble fiber. So this would not be something that I wanted to give to somebody with constipation. It may make the process worse. So I want to make sure that I'm giving something that has both types, because nature is not stupid. So food has generally a combination of soluble and insoluble fiber. So vegetables and fruit, obviously the soluble fibers are going to be on the inside, because if they're on the outside, they dissolve when it rained. But the skin is not, so that's going to be our bulking agent, which is going to speed the process of moving food through the intestinal tract. So gastrofiber and whole food fiber are a combination of soluble and insoluble fiber to support the digestive system and improve that bowel motility. So if we start to correlate our information, so I've obviously done my symptom survey, and I may have some 2s or 3s in group 6, particularly questions 99, 101, 102, 104, and obviously paying attention to question 36, because constipation can play a big role in lower bowel function. I'm going to be looking at other things like, talking about their poop. That's the changes in bowel habits. Do they have any food sensitivities or intolerances? Do they have lactose intolerance? Have they had any history of Giardia or irritable bowel syndrome? Are they eating a high carbohydrate diet? All of these things can influence how the small bowel is working. The objective things that I'm looking for are tenderness around the umbilicus and around the colon, obviously bowel transit time we talked about, some stool testing, which we'll talk about in a minute, as well as secretory IgA levels that we mentioned. Well, when I'm looking at, oftentimes patients come with their CBCs. I'm always taking a look at eosinophils. Eosinophils tell me a couple things. It tells me parasites, which I can correlate to their symptoms, or it could just be allergies, because allergies will raise that eosinophil count. And when I'm thinking that, then I'm looking at portal circulation and things like Antrax. Obviously, if they've got any colonoscopy reports or exams, I want to pay attention to that or ask them if they've had that. And I'm also looking at some simple things like their tongue and their frenulum, which is that little flap of skin between your lip and your teeth. So those are things that I can point out to them that they can track at home and see how that's changing or how that's improving. So it's important that we do not rely on just the symptom survey. It's important that we correlate those symptoms with objective findings so the patient understands what it is that we're trying to achieve. So, Nancy, this little pimple or cyst or bump on your frenulum suggests that there's inflammation in your colon, your bowel, which is consistent with what your symptom survey is telling me, that you're having episodes of diarrhea and constipation and lots of gas. So I want to give you this, this, and this to influence that. So now she's got some homework. She's paying attention to those objective findings so that we can go back and really, I guess, prove what we're doing is working. When we do that, we become a wizard. So let's explore some of those objective indicators. So the first place I start is I usually give the patient a little bit of a heads up. Say, listen, I'm going to be palpating or touching your abdomen. I'm going to be working around your navel and around your colon, and I'm going to start very, very lightly at first, and I may grab their hand and palpate their hand and kind of give them an idea of how much pressure I'm going to be putting. So in 95% of my patients, I can go right in and touch their belly, and it's not that big a deal. But there's that 5% that is extraordinarily either ticklish or hypersensitive or has some really obnoxious, intestinal troubles, and that can be really, unsettling for them. So always go slow when we're doing this. I start around the navel, and I sort of kind of work around the navel at 12 and 3 and 6 and 9 o'clock, and I'm just kind of gently palpating around the navel and feeling for tautness or sensitivity. This is not a specific indicator. This just tells me that there's tension in the abdomen. So there's probably some inflammation or an increase in inflammatory cytokines, little chemical mediators from the immune system in the gut doing its job. So the lymphatic ductwork in the omentum and the mesentery is a little bit backed up. It doesn't tell me why. It just tells me that there's a problem. So it could be parasites. It could be a leaky gut situation. It could be a colitis, any number of things. From a chiropractic perspective, I tend to correlate that to subluxation around T10. So I'm always, I work with most of my patients in both a nutrition and a chiropractic fashion. So I'm making sure that I'm addressing and adjusting T10 if that's necessary. Then I move into the large intestine, and the large intestine is, I usually start from the cecum, ileocecal valve, and work my way around. So if the patient's ASIS is like right here, and their belly button is like right here, if we draw a line between the two, about a third of the way is typically where you're going to find the ileocecal valve and the cecum in the lower part of that ascending colon. So I will just kind of gently take both of my hands, fingertips, and I'll palpate myself up the ascending colon, across the transverse, and down the descending colon. This takes a little bit of practice, and after a while you'll start to determine the difference between, that's just poop and a little bit of gas versus a situation where that large colon is actually inflamed and irritated. But what's important about that is notating it. So, Julie, do you feel that pressure, that sensitivity there? And she may be wincing. She may be, trying to get away from the pressure of my fingers, which isn't very much. And when she says, yeah, I do feel that, I want to notate that because I want to be able to come back in the next visit or 2 visits later and reassess that. And when that's gone, I need that to influence her, because we all have those patients that we've cured their leprosy, and we taught their kids to walk, and their hives, their bumps, their diabetes is cured, and their cervical discs are all better, and and then eventually in a year they're just like, I just don't think you're working anymore. I just don't think you're like, what? Anyway, if you notate those things, then you can bring those back and say, well, remember, Julie, 2 visits ago, I could hardly touch this area of your tummy without you jumping off the table. And now I can get in there and put some pressure in it. So it suggests that we're reducing some of the inflammation in your colon, and that's a good thing. So we're going to palpate the colon for tenderness while determining the level of discomfort. In general, when I'm seeing excessive pain, that's an indicator for things that are going to improve or influence the ecology of the gut. So simple things that I think of and profound things are Zymex, Spanish black radish, and or lactans at around 6 a day. If that patient is experiencing some constipation, I may do Fincho at 6 per day. I'll also correlate that to my liver biliary findings, and I may have them do, like the beet that we talked about, or if they're not a big beet eater, I may do some beta food or some AF beta food. In situations where there's like a severe constipation or a really chronic, persistent constipation, that's where I start to talk to the patients about tone. The large bowel, being smooth muscle, needs to have a certain amount of tone to eliminate and get that peristaltic function to push that fecal mass down and through and out the door. So if over time you have overstretched that large bowel, it loses its ability, it loses its tone. So things like Colax, which is a product that I don't use a lot of, but I respect it because it works really well. It has things in it that are going to improve the tone and get you moving. It's a little bit of a laxative, but it's really going to get that small bowel, or sorry, large bowel, contracting a little bit more efficiently. So it's not uncommon to have patients be a little bit uncomfortable taking Colax because their colon is I hate to say cramping, but it's contracting in a fashion that it's not used to. So if you use a product like Colax for 2 or 3 or 4 weeks consistently, that's like going to the gym for 2 or 3 or 4 weeks consistently to build the strength and the tone back in the muscles of the colon so that it can have that more normal peristaltic action. So I wouldn't want to use Colax long term, but I think it's a great, therapeutic exercise for the colon to get that tone back. And if for some reason they have really watery or loose stools, that's when I do something like Colacol 2, which has some bentonite clay, which is very adsorbent and tends to hold that water and kind of gum it up so that it's not as fluid, and that'll slow things down. So the other part of the nutritional exam for the large intestine is to look at the iliotibial bands, the IT bands, and let's look at this from maybe a little bit better picture. So the digestive system on the iliotibial bands starts at B and goes to A. So as you're palpating up that patient's iliotibial band, you're assessing the transverse and ascending colon thusly. So if you palpate from here to here, it's as if you're palpating from here to here. So sometimes what I will do before I go into the patient's abdomen is I will palpate from here to here, and I may find a sensitivity, say like right here. So that suggests to me to next go somewhere in this neighborhood to look for that sensitivity in the colon. The niceness about the iliotibial band check is I can be a little bit more aggressive on those. I can really get in and dig on those, whereas it would be maybe not as pleasant for the patient for me to get in and dig on these. Similarly, so from this part of the colon down would be from this part of the iliotibial band up. So it's almost like they have a little apron on, and we unhook the apron up here, and we fold this down to here, and that's how the colon sort of sits on the iliotibial bands. So this is an opportunity. The iliotibial band is a great place where I can utilize uh, a neurolingual testing. So neurolingual testing is something we haven't talked about yet, and I'll just kind of broach it here briefly. This is an option for me to test a supplement to see its effect or its efficacy. So I may be in a quandary. Gosh, do I use Zymex for this patient, or do I use lactic acid yeast? So I can palpate that obnoxious tenderness here, and the patient says, you know, we can grade it. I can say on a scale of 10, how bad is that? And they say, well, it's a 6. And so I put a little Zymex in their mouth and have them chew on it for a moment. They can swallow it or they can spit it out. Usually I have a little water available for them. And then I go back and I palpate that same spot. When I'm doing this, I try to keep my hand right on the spot so that there's no question as to whether or not, well, you're not in the same spot. I keep my hand on that spot, administer the Zymex or the Zypan or the lactic acid yeast, the product that I have in question that I may be comparing to, and say, does that feel any different? And if they're like, whoa, doc, that's much better, that's the product I'm going to use. If it doesn't change it, then I may go to my secondary product and try something like Lactins or Prosymbiotic or some other product to see if that influences that sensitivity along that iliotibial band. So the frenulum, so after I've had the patient open their mouth and say ah and stick out their tongue, and I look at their tongue, and if it really looks coated or bad, I typically tell them to go look at that in the mirror. When the next time they're in the bathroom. So I want you to take a good look at your tongue, because I think that this is something that's going to improve as we improve your digestive health. The tongue can be from a myriad of reasons why that coating is on the tongue. It could be from gastroesophageal reflux. It can be from liver toxicity, bowel toxicity, lots of things. But ultimately, as we're improving detoxification pathways and digestive pathways, the tongue usually gets better. Similarly, this little flap of skin here is called the frenulum. We have several of these, but the one I'm looking at is the one on the top lip. The frenulum on the top lip, if it has a pimple or a cyst or a bump or a swelling in it, is reflecting the status of the bowel. So typically the cysts that are a little closer to the teeth tend to indicate more of a small intestinal irritation, and lumps or bumps in this neighborhood tend to be more of a large bowel. When I see these, I have patients go look at them. I say, I want to see if we can influence that and see how that changes, because this is a mirror into the integrity of your bowel. And usually I show them mine while they show me yours, and we look like monkeys, and it's funny. So the next set of objective findings, those are the kind of easy in-office ones. The next step that I take on a more difficult case is to go ahead and do stool sampling. So the company that I utilize for stool sampling is a company called Metametrics, and in the notes that I'll post on the webpage, this will be a hyperlink that'll take you to their webpage. And the thing that I like about their style of testing or sampling is they do DNA testing, so they're very capable of determining what's in the bowel, what's in the colon, even though it may not be leaving the colon. So most bacteria do a pretty good job of not being, uh, you know, evicted from their comfy little parking space in the bowel. So, but they do have metabolic waste, and from those we can determine their DNA, and we can check that in the stool. So this is by far the most effective means of looking at beneficial, opportunistic, and pathogenic bacteria, as well as yeasts and parasites that I'm aware of. And above and beyond that, they'll look at, for instance, if they find a pathogenic bacteria, they will make tests as to what is effective at eliminating or killing that. So they may check it against the typical anti-parasitics or anti-protozoals like Flagyl, and it'll say, you know, it's susceptible to Flagyl, or it's susceptible to berberine or these botanicals. So when I get a difficult case, this is really influential because I can tell the patient, look, we found what's in your gut, and not only have we found it, but I don't think there's anything that I can do from an herbal standpoint to influence this. Let's go ahead and do something like a prescription drug like Flagyl so that we can eradicate this bug. Now, if we're going to do something as radical as a prescription medication like Flagyl to eradicating this bug, we're also going to be eradicating some beneficial things at the same time. So this is where I'm going to be able to help you immensely, is that we're going to clean up the mess from the pharmaceutical approach. And maybe one or two cases in the last 5 or 10 years, I've had to go this route where we, did have to refer out and work with the patient's medical practitioner to affect some changes on some really difficult bacterial bugs. So the other test that I mentioned earlier was for testing secretory IgA, which is part of the adrenal stress test that's provided by a company out of Washington called Diagnostics. This is a fairly simple salivary test, and it will give a readout of the concentration of secretory IgA. So secretory IgA is sort of an indirect measurement of the integrity or health of the immune system as we interface with our external environment. If those levels are low, then I know that our immune interface, which is our small intestine, is not as robust as it could be. So I will treat that not only from an adrenal standpoint, but also from a gut integrity standpoint. Which brings us to the host of things that I'm thinking about when I'm looking at digestive function, in particular bowel dysfunction. So I know I need to support those tissues and encourage healing. So the products that I utilize for that, you can see it's a host of them. We'll talk more about that in the next slide. The next thing I want to do is I want to look at pH. I want to improve the acidity of the bowel. That makes the environment less hospitable for opportunistic and pathogenic bacteria. And finally, things that are going to help detoxify or cleanse the colon. And that's a simple way of looking at the three things that I want to do for bowel integrity. So with regards to tissue support and healing, I'm not going to read this entire slide, but you get the idea. Is what we're trying to do is improve the health of those enterocytes, so those actual non-immune small intestinal cells that are there to absorb nutrients. And things that I do for that primarily are going to be ochrapepsin and cataplex AC. Ochrapepsin is primarily okra, and it has a little orchic extract, which is the source of vitamin E3. It has a little bit of pepsin. Pepsin is important for improving the digestion and breakdown of proteins, and it has a little bit of allantoin, which I've talked about in some of my Montana Nutrition collaboration. There's a lot of allantoin in several different products, and what it tends to be put in for is tissue healing. Allantoin really is really demulcent at healing tissue. So allantoin is the sort of active ingredient in comfrey. And from a homeopathic standpoint, I use comfrey for things like fractures and broken bones, but it's also for injuries to tendons and sinews and connective tissue. And epithelium is a connective tissue. So that allantoin is a very important component. Of course, the mucilage in the okra is very beneficial for the mucus component of the stomach, as well as the small and large intestine. The pepsin component is good because it helps to break down proteins into its constituent amino acids. I think we spoke about that a little bit last time, but I'll cover just a little bit of how I speak with patients about that. Is proteins are made up of amino acids, just like words are made up of letters. And when I eat food, I'm eating whole words, I'm eating whole proteins. It's my stomach and digestive enzymes' job to break those proteins down into their constituent letters where I can absorb them and put them in my liver and make all my own new words. Those will be mine because I made them myself. Now, some words are offensive, and I might use a four-letter word of some variety, and I may say, well, the letter S by itself is not that offensive, and the letter H is not that offensive, and the letter I is not that offensive, and they start to kind of put it together. And I say, but you can see, whereas if I added one more amino acid, that could be a word that becomes offensive. That would be a whole protein. So what I want to do is, those letters in and of themselves are not problems. So if I have effective protein digestion, I don't have anything offensive going through my small intestine that my immune system has to get worked up about. Of course, the pepsin also helps break down excessive mucus covering on those villi. If I've got too much snot on those villi and microvilli, I've just decreased the surface area of my tennis court. If I don't have that full tennis court of absorption, I don't get all my nutrients. And if I don't get all my nutrients, I might feel fatigued. I might feel tired. I might feel cranky. I might have a little tummy upset. And it's amazing how frequently people come in and complain of those things, and you start improving their digestion, and so many things get better because we're only as good as what we absorb. And that's why it's important that we're improving that small intestinal function, ochrapepsin being the premier primary product that I like to use for that. Of course, it's going to help with colitis and gastric inflammation. That's the allantoin really heals that tissue. Um, and I'll occasionally use it for heartburn relief, and I use it in my ulcer patients as well. We talked about that last time. And it's just kind of a general bowel cleanser. So the thing that's important about ochrapepsin, if you want to get the most bang for your buck, is have your patient take it between meals. So 2 capsules 3 times a day between meals. And the reason for that is because those digestive enzymes are going to work on the food if you take it with food. But if you take it between meals, it's going to help clear that excessive snot layer out of the small intestine. It's going to work more efficiently. So that would be 1 hour before mealtime or 2 hours after mealtime. So the other thing that we're trying to do in the small intestine is influence the pH. And what often ends up occurring when the stomach is not working effectively, and we're not digesting our food, and we're not getting a good hydrochloric acid production, the rest of the bowel tract starts to suffer and actually becomes a little bit too alkaline. And when the gut becomes alkaline, that's an environment that is hospitable to opportunistic and pathogenic bacteria, and particularly ones that make gas. So when we're looking at questions 99 and 102, we're seeing people that are creating a lot of gas after they eat. So this tells me that their intestinal microflora are imbalanced as a result of a pH problem in the intestine. So the two things that I investigate is either Zymex or lactic acid yeast. I tend to do Zymex a little bit more frequently, but basically what these guys are doing is these are helping to acidify the colon. By doing that, we're going to make it a less hospitable environment and get rid of those gas-producing organisms. So the thing that makes Zymex and lactic acid yeast really unique is that these are a type of yeast that can feed on any carbohydrate. So for a person like me who does not consume any milk or dairy products, to do a product like acidophilus is not very effective. I'm not going to feed that acidophilus very well, and so it's not going to do as good of a job as something that can eat anything. So lactic acid yeast is our yeast of choice to acidify, because when it eats any sugar, any carbohydrate in the diet, it's going to turn that into lactic acid, and that's what's going to acidify the colon, and that's why they call it lactic acid yeast. So those are the two main pH changers in the colon. And finally, from a detoxification standpoint, we already talked about ochrapepsin, and we paid a little bit of attention to fiber. So there's a couple of other products that I like to do that really help with detoxification. Primarily chlorophyll. I like chlorophyll because it does so many good things. Chlorophyll is the blood of the plant, and our blood is our life. And if we can nourish our blood, we can detoxify our bowel, we can neutralize guanidine. This is our detoxification product. Spanish black radish is a little bit more of a liver detoxifying, but I think it also helps in the bowel. In fact, I'd go so far as I know it helps in the bowel. That sulforaphane may facilitate the eradication of H. pylori, which is what's going to be present in patients with more upper digestive problems like ulcers. So the other way I think about bowel function, particularly in cases where I know I've got an infestation or a problem with a parasite or an overt dysbiosis, is I think about weeding, seeding, and feeding. So this is where I talk to my patients using the metaphor of my yard. So in my yard, if I have dandelions, I have to weed it. I can either do that chemically or I can do it manually. However, if I do it chemically, like I don't have the ability to manually pluck out bacteria from some of these colons, so I have to do it chemically somehow. And that's by changing the environment. That's with things that are going to improve pH. While you'll see on weeding, some of the things are Zymex. Lactic acid yeast can do some weeding because it changes the pH. So once I've pulled those dandelions, or in this case I've chemically killed them with an herbicide, the problem is most of those herbicides are going to affect the neighboring grass, and so I may lose some grass. So at the extreme end of the spectrum, some of the antibiotics and antiprotozoals are excellent weeders. However, they're so effective they kill our good bacteria. That's why we need to seed the yard, get the grass seed down so that we can grow that grass back where it had been killed. If we don't do that, then the next bit of wind is just going to blow that next dandelion tuft and start growing. So anytime I've got a patient doing an antibiotic, I talk to them about the importance of seeding with good probiotic. And then, of course, once you have a nice lawn and it looks all great, you want to feed it. You want to keep that grass healthy. So things like gastrofiber, prebiotic inulin, whole food fiber are excellent ways of keeping the intestinal tract nourished. So weeding can be kind of two things. It can be kind of an infestation of parasites, or it can be a dysbiosis. So when I'm looking at an infestation with parasites, I'm considering things like multizyme, which is a proteolytic enzyme that's going to break down or disrupt those cell membranes of the protozoa. Same thing with Zymex-2. Of course, same as ochrapepsin. If we want to affect what's living in the small intestine, we want to take that between meals. We don't want that working on our food. We want it working on our gut. Vitanox is a product that I cannot encourage enough. It's terribly expensive, but amazingly effective. So I use it for all sorts of things, but it does an excellent job of making an inhospitable environment in the colon for pathogenic bacteria. Wormwood complex is probably the most powerful product that I utilize with regards to affecting parasites, and gut flora is probably number 2. I use gut flora probably more commonly than anything on this page, except for maybe Zymex. Gut flora, when it came out, became my new kind of go-to all-around guy for improving the habit or the environment of the intestine. So that there's oregano oil and andrographis and philodendron. So that andrographis is really immune enhancing. And when you consider that 60% of our immune system is in the small intestine, that's why that andrographis is in there. We're really improving our interface. We're improving the pay of our TSA check stations. And that's exactly how I would tell it to a patient so that they sort of understand why I'm doing it. Philodendron is a very high source of berberine, and berberine is very antimicrobial, particularly against candida. So as we move more into the dysbiosis portion of weeding, that's why I use gut flora in both the infestation and in the dysbiosis situations. Of course, we talked about Zymex and its pH lowering capacity. And the other thing, golden seal is basically berberine, which is going to be our really big candida killer. The only thing we haven't talked about is garlic. The enteric coated garlic called Garlic Forte from MediHerb is an excellent compound for improving the environment of the small and large intestine. It's that I can't even pronounce it. That sulfur-containing compound that suppresses the growth of candida and improves the growth of your good bacteria. So that's not only a weeding product, but it can be a feeding product as well. Seeding. So the seeding products that we have are lactins, which is a source of lactobacillus and bifidobacter. But the product I've been using more of lately is the ProSynbiotic. This is a product that has 4 strains of probiotic microbes, and when I need to do any sort of feeding, this is my go-to product. There's cyro yeast, lactic acid yeast, Zymex is creating that pH environment that we're looking for, and of course the Vitanox I mentioned briefly for the health and support of the healthy bowel flora, which is really should be under the feeding component, which is this slide. So when I'm looking to feed, I'm looking for those, what do they call it? The little sugar molecules, the small sugar molecules. So probably the most profound feeding is going to be the prebiotic inulin. And you'll notice that ProSynbiotic has inulin already in it, so that's a great addition. So I don't have to send the patient home with 2 products. I know that the bacteria I'm giving them has the food necessary to help encourage those bacteria to grow. Same thing, but if that patient has constipation, that if I were to do prebiotic inulin by itself, I could slow that transit time. So I would be cautious of using the inulin by itself, but I think it's still perfectly safe to use the ProSynbiotic in cases of constipation. Just be aware of the potential. So for patients with gut flora imbalances, we want to address the cause of dysbiosis. And a lot of times that has to do with poor digestion anywhere along the digestive tract. So I don't get too excited about small intestine and colon until I've given some time for upper digestive tract stuff to change. So if they're having a lot of heartburn, indigestion problems, stomach northwards, I want to give Zypan and hydrochloric acid and multizyme and things like that time to work, because that may improve digestion to the point where I don't need to do a lot of lower bowel function. Of course, I'm paying attention to antibiotics, heartburn meds, things like that that can really screw up the system, making sure that they're staying away from a diet that's too high in carbohydrates, and I'm addressing food sensitivities and leaky gut as that comes up. I encourage them to drink a lot of water, and I encourage them to eat a lot of lacto-fermented foods, so sauerkraut, pickles, things of that nature. Obviously exercise, and making sure that their eating environment is appropriate. So for parasites, I have a protocol. I typically do gut flora 2-3 times a day for 6 weeks. And I have them on wormwood complex at 2 tablets twice a day for 10 days. I'll have them rest for 10 days and then repeat that. And I'll do that off and on for 6 weeks. So that'll be 3 weeks or 3 10-day periods of being on the wormwood complex. And Zymex to improve that pH of the colon. If there's any constipation, I'll add Fincho or Colax, or make sure that they're eating some beets really regularly, basically ensuring that I'm keeping the colon flowing well. And then when I've done that, I'll typically move them into a dysbiosis protocol, which is where I'm doing gastrofiber 1 or 2 to 3 times a day. Golden seal, I don't use a lot of golden seal, but I think that the berberine within gut flora complex is going to be adequate. Prosymbiotic and lactins, I usually pick one or the other. I don't frequently do both. And then on the weekends, I have them taking the gut flora 2-3 times a day. So I want everybody to remember that the first step to successful nutritional therapy is digestion. We've got to pay attention to this. The digestive system works from the top down, north-south. If you have a problem in the colon, look to the upper digestive tract first. If in doubt, always start with the big 3, stomach, pancreas, gallbladder. Those are extremely important. Next time we'll get into a little bit of liver and gallbladder. If patients aren't getting well, even with lifestyle changes, make sure they're chewing their food. Check their salivary pH, check their stomach reflexes, check their back for subluxations. And make sure that we're Um, Taking care of the things that are maybe outside the norm. So this is the kind of the psychic component of our patient work. So if we've got a patient who's majorly stressed, just lost a spouse or their house burned down, that's a that's a life event that may be more profound than what we can do with with some supplements. But helping that patient cope with that is the main thing. So we're reaching the end of the presentation. I'd like to present a few opportunities of learning that's coming up. Dr. Michael Gaeta will be in Billings, Montana in June, June 15th, and the study groups in Boulder, Denver, Loveland, the Montana teleconference, and our quarterly evening teleconferences are all other opportunities to get more education on how to improve your nutritional practice. So I'd like to thank everybody for joining us. That was pretty good timing. We made it in about an hour and a minute. Next time will be session 4, where we'll be going over liver and biliary. And I'm going to shrink the presentation so I can look at chat. If there's any questions, you can go ahead and put it in the chat menu. And I'll stay on for a moment and answer those.